Welcome all the viewers to Dr. K.K. Agarwal Medtalks show in association with ISSCP, Heart Care Foundation of India, Talking Point, and USV. I think this is one of the program which is acclaimed across India as well as at the international level, where millions of viewers are seeing the Medtalks, which are basically pioneered by Dr. K.K. Agarwal. The main objective was bringing out new science into the practice and how all the doctors will be channelized so that this science will be clear cut into practice. And the concept we are discussing in the last some programs is basically the role of probiotics and the new dimension to the probiotic usage in the clinical practice. So whenever you talk about gut microbiota, obviously it is a core for gastroenterology. So today we have got one of the most popular gastroenterologists. Welcome, Dr. Umesh Goyal. He's a professor of DMC. He's a scholar throughout the medical career. I think he can become one of the symbol for all the MBBS as well as postgraduates. So many
Thank you.
awards he has got during his curriculum, and in the shortest period of time, so many publications, because he are not only restricted to his academics but almost over 100 publications. He is an editor in some journals and even the reviewer in many journals and lots
Thank
of
you so much.
awards. I think couple of awards I have to mention for all the viewers is one is Young Clinician Award and the Young Investigator Award. So I think he has seen both the very important that the evolution of the science as well as practice. So I think he's the right doctor to guide us for this. Welcome, sir.
Thank you.
Yeah. I think one of the very important point is gut microbiota. When we started long back, 20, 30 years back, at that time, the research about gut microbiota was relatively rudimentary phase. And over a period of time, today you go to the Medline and put the word gut microbiota, and the role of gut microbiota not only in the GI diseases but also a variety of ailments, whether it is diabetes or obesity or in the field of not only neurology. So I think each and every field we are seeing the importance of gut microbiota. So, Dr. Umesh, what do you think that the gut microbiota research evolution in the last 30, 40 years?
Yeah. Good evening, everyone. First of all, I thank for inviting me for this show and one a very emerging concept. It has been in the past many decades. There is a lot of research on this topic, and it is still going on. And truly speaking, still we do not have very firm data of this exact composition of gut microbiome and exact probiotics to be given, how long to be given, what is to be given. The research is ongoing, and we expect better data in future. But as for now, yes, one thing is known, that gut microbiota, as Dr. Mesh rightly said, is a very important component of our body. In fact, the number of microbiome cells in our body, which are more than 10 to the power 14, that is even more than the human cells in the body. So we are more of microbiome than of humans, which we say. And this fact was clearly told years back by so many scholars, that gut microbiome affects the many functions of the body. And today we know that it's not only GI. More than 90% of the diseases of the human body, they have shown to be have some association with gut microbiota. So this speaks so loud about the importance of microbiomes in our body, that more than 90% of diseases have been linked to the difference in composition of the microbiota. And then the next step is the efficacy which is being tried of this probiotics in the treatment of such diseases. So this is a great link of GI and many non-GI diseases.
Yeah, I think a very important point Dr. Umesh has come out with is that 90% of the diseases have got there is some link with the gut microbiota. I think this is a very new science he has put forth. I think everybody has to keep in mind that whenever we are managing any diseases, also look into is that the gut microbiota is very important component. Uh, Coming to one very common disease, obviously febrile illness, whether it is a viral or bacterial or other illnesses, and bacterial infections, we use antibiotics as a very common because they are life saving. They reduce symptoms, they reduce kill bacteria. But I think one of the problem with antibiotics is dysbiosis. So, what is what are the different antibiotics, or how is the dysbiosis problem with antibiotic in practice, sir?
So again, a very, very yes, important question for all of the doctors, all clinicians, because everyone is using antibiotics in their own fields for one of the reason or the other. And we know that in especially in our country, India, where there's no prescription audits, there's no guidelines. So patients are giving antibiotics by doctors, even by chemists, and even by themselves. People are taking antibiotics. So that is the reason why antibiotics misuse, we call, in India is happening. And besides the other side effects of antibiotics, I think the most important, which Dr. Mesh has highlighted, is yes, it is the dysbiosis. Dysbiosis basically is the term uh, given to the alteration of microbiota. So as I told you initially, there's no fixed definition for a normal microflora in a human body, though we have a gross idea. And dysbiosis, again, there's no fixed data, no fixed again composition. We cannot say because we don't have so much data right now, because the microbial composition varies so much from place to place, from even from person to person, even in a family. I mean, two brothers and sisters, they might have a different composition. So, but one thing is certain, that giving antibiotics, it disrupts. Antibiotic has to kill bacteria, and it does kill also the normal flora. So, besides killing the pathogen which we are treating, this we all should know that it will kill the normal bacteria which are present in our body. And thinking this, we should be very, very judiciously prescribing the antibiotics, because we, as I said, in India, they are being given for any other febrile illness. Maybe it's viral, it's like a diarrhea, which we know that most common cause of diarrhea is viral diarrhea. But still, anyone who has diarrhea, he takes the antibiotic himself, or by a chemist, or maybe by a doctor. So all this misuse is happening, which will be affecting the gut microbiome. So antibiotics, when they kill the gut microbiome, they will reduce the diversity of the microbiome. So your question, like, what will they do? So first of all, the diversity will reduce. And so the microbiome, the other pathogens which the antibiotic not affecting, the bad ones, they might overgrow. This is number one. Number two, we all in our normal microbiome also, there are few bacteria which are lying, which might be having resistance to this antibiotics genes. So when we give antibiotics, the majority of the bacteria who are sensitive, they will die. But the ones who have resistant genes for these antibiotics, they will multiply, because these antibiotic will not cover that. So by giving this antibiotic wrongly, we are giving those chance to those bacteria to multiply. So when they multiply, they will create a host of their army which is resistant to that particular antibiotic. And the next time when you take that antibiotic, they will not work on that bacteria. So so this is, I mean, this is the reason for rising antibiotic resistance in our Asian population, especially Indian population. You know, the antibiotics like quinolones, which in West you need a proper prescription, a reason for prescribing these quinolones, like ciprofloxacin, ofloxacin, and there the resistance to these quinolones is just 10 to 20%. While in the data from Asian countries show the resistance to be around 40 to 50%, while in India the resistance of like enteric pathogens to quinolones is up to 80 to 90%. So this is very, very alarming scenario going on, that by altering the normal microbiome, by giving overuse of antibiotics, we are creating a lot of resistance for this antibiotic, for this bacteria.
So I think Dr. Goel is rightly telling is that dysbiosis and antibiotic link, many people are aware about it, and many times after commonly penicillin group, amoxicillin, amoxicillin, clavulanic acid, these are immediately. I think do you think that the susceptibility of developing diarrhea is increased in during your practice now? In your practicing for over 20 years,
Yeah.
antibiotics
So
inducing diarrhea.
definitely. Again, yes, the about the side effect of antibiotics, I discussed resistance. The second is what we call as antibiotic associated diarrhea. So, being a gastroenterologist, we out of the patients which I receive, I think around 30 to 40% people, they come to me with diarrhea if I take a proper history, and they have received a course of antibiotics. So, in my practice, 30 to 40%, I would say, are the diarrhea which is antibiotic associated diarrhea. This is not a true infective diarrhea. Most of the people, most of the common antibiotics which cause diarrhea are the ones which are used for tooth infections, skin infections, like amoxicillin group and azithromycin, and other for URI, for I mean chest and skin and tooth infections. So people do have a history of taking these antibiotics in the last few weeks, and after that they have a diarrhea. They go to a chemist or go to another doctor, they give him another course of antibiotics, which is a quinolone or a cefixime group. They still continue to have a diarrhea. Then they go to third person. Well, people have received 2 to 3 courses of antibiotics. When they come to us, if you take a history, there's no fever, no, on examination there's no pain, no tenderness. So this is what a clinician should do. Then these are the signs of active infection, pain, tenderness, fever, leukocytosis. All these are not there, they are just having diarrhea. And on taking history, you come to know, you stop all the antibiotics, give them probiotics, give them dietary instructions, and 90% would be okay with this. But yes, some people who do not improve after this, then there's a next topic I think we'll be discussing, that is a clostridium difficile infection, which has to be ruled out. We'll be coming to that I think later. But what is that and how to assess that?
Yeah, absolutely. I think one of the all clinicians should understand this important fact when the doctor has shared his own clinical experience that he is getting 30 to 40% of the cases with diarrhea, and there is some link with the antibiotic. Today we are also talking about one important point, and that is a research point, as you are told that it is ongoing research and futuristic research. Is one of the point is PPIs. I think PPIs are the bread and butter for gastroenterologists, physicians, surgeons,
Yeah.
right? They are used so
Yeah.
rampantly, and as well as the family physicians. So,
Yeah.
PPIs are must in many conditions. So, which are the
So
common
after
conditions? I think PPIs should be restricted. Yeah.
Yeah. So again, a very, very important thing as far as our country is concerned. Our country, because there's no restriction of giving any drug to anyone. So I mean, PPAs they come foremost. They come even before antibiotics. I mean, there is you will rarely see a prescription without a PPI coming out of a medicine or a GI OPD in our country, especially I know in my part of the country. And even in indoor patients, there was a study published. Even actually, I was writing an article on PPI and prokinetics. I'm writing a review article in that. Then I came across so much of literature in which they did a hospital surveys, and they found that more than 60% of the prescriptions for PPIs they were wrongly given. So PPI, the only indications are peptic ulcer disease, which and GERD. These are the only two strong indications of giving PPIs, in which you really help the patient by giving PPIs. Then you are not afraid of side effects, because the patient with peptic ulcer maybe dying, maybe having a lot of pain, maybe having bleeding. You want to control that. A patient of GERD will develop esophagitis, will develop bleeding, will develop stricture and malignancy. So in these two conditions, yes, you have to give PPIs, because the risk benefit ratio you have to see is the benefit is much higher than the risk involved in giving PPI. So these are the two conditions which have been approved by US FDA and maybe other agencies also for giving the PPIs. Then come the other common indication which PPI is given are functional dyspepsia, which is I mean which compromises a lot of population coming to GI and medicine OPDs. In that, the role of PPI is still not very certain, but yes, you can give a low dose PPI, see the response, and then if a patient doesn't respond, you go to the other test and other evaluation. So these three things. But as I said, in our country, any GI complaint or any with a patient may be coming with a URI, you are giving some antibiotic along with PPI along with multivitamin. So this is the most common prescription seen in our country: mixture of PPI, antibiotic, and a multivitamin. So this is going on. And so PPAs, what will they do? So coming back to the basic thing, we have a normal gastric pH, which is to be maintained by the gastric acid less than 4. Why do we have that? Because this is the first entry of the whatever we eat, whatever bacteria go through our mouth to a stomach. This acid will kill 90% of those bacteria in 15 minutes, because most of the bacteria are acid sensitive. So this is the first line of defense for the bacteria which enter our mouth through the food. And second is the mucous lining of the stomach, that will also prevent the translocation of bacteria. Whatever bacteria survive, they cannot pierce the gastric wall and go to the blood, because there's a mucous lining. So low pH and the mucous lining, they are the first line of defense against bacterial infections in our body. What do PPS do? They will disrupt both of the things. So PPS will raise the pH, because they will suppress the acid production. So the pH of 4 is the barrier after which infection start will occurring. So whenever pH will rise more than 4, whatever bacteria enter, they will not be killed. Number one. Number two, PPS disrupt the mucous layer also. So number two, mucous layer will also not be there. So bacteria enter, they are growing, they are not killed. They enter the mucous layer, enter the stomach and reach the bloodstream, causing infections. So this is one part in stomach. But PPAs have further things, further links also. Lower down, they affect the microbial composition in the small intestine also, by altering the motility of the small gut, and they alter the microbiome in the even in the colon also. So in the small gut, what they do is they cause SIBO, which is small intestinal bacterial overgrowth. So this is entirely different topic, but in short, I will tell SIBO is when bacteria change their place in the body. They are the normal bacteria of the colon. When they come to the small gut and they are present there in the composition of more than 10 to 10 per 5 CFU per ml. This is called small intestinal bacterial overgrowth. This is different from infection, because in infection we have bacteria coming from outside which is causing the infection, while SIBO is bacteria translocating from the colon to the small gut. And yes, PPI are one of the factors which increase SIBO. Then SIBO itself has so many manifestations like bloating, diarrhea, malabsorption, and all those symptoms coming up. So, in nutshell, PPIs cause dysbiosis by altering this by lowering the pH number one, and through their other effects, they cause SIBO, and in this way, they disrupt the entire bacterial population of the human microbiome, human gut. I mean,
So I think all the doctors have to realize one important point, that PPIs are not the great kind of a drugs which will be. Many people think that the acid suppression means gastroprotective, and then there is a gastrointestinal
yeah.
protective. But I think there are the two strong mechanisms doctors talked about. Is that you can't suppress acid for months and months, right? So that is one of the important point you highlighted. I think everybody has to keep in mind, because we write these PPIs for 3 weeks, 6 weeks, 8 weeks. People, patient doesn't come for follow up. He's taking, because he's taking 7 drugs, therefore his PPI is added. And that is another concept which is there in the practice. Whether the
So, like
cardiac person, yeah,
yeah. Even in patient of
yeah.
IBS who has symptom origin due to different things. So I mean every pain abdomen is not peptic ulcer. Every pain abdomen is not due to acid. So we have to think the origin of the pain. Like IBS is totally a condition not related to any acid secretion. It is due to the GI pathology. The altered There are so many factors in IBS: visceral hypersensitivity, altered gut microbiome. In fact, in that the microbiome is already altered. If you give more PPIs, it will get more altered. Patient will worsen instead of improving. So this is the thing that if you use it judiciously, then you will have even worsening of symptoms of such patients who already have IBS or clostridium associated diarrhea. So that is why this has to be very very judiciously used, and then tapered off. Even if peptic ulcer, it's not that lifelong patient has to take PPIs. It is a specific period. In 6 to 8 weeks ulcers normally heal, and then you have to withdraw the PPIs.
So I think one important point doctor is mentioning is that look at the duration of PPIs and withdraw it, and strongly withdraw it. It's not like that कि patient, sir इससे मुझे ठीक लग रहा है तो मैं लेता हूँ, right? That you should not be emotionally attached to the patient, because if you can harm the patient in these aspects, right?
Again, one small point again. So patients are used to taking PPIs because they consume a PPI and then they want to eat anything they want. Like we know that people, the things which increase acid secretion, like spicy food, hot tea, coffee, non-veg food, and I mean smoking, alcohol. So I mean all those things. So they know that when they have taken PPI, they suppress the acid and then they can everything so that they get less symptom. That is the main reason in what I see in my OPD, whereby people don't want to stop the PPIs. But then you have to strongly tell them that no, this PPI will cause side effects, so many side effects. It's better you take diet control, better stop alcohol, smoking, and all those spicy and hot foods, and then you will get relieved. And yes, the patients who understand, they are able to stop the PPIs entirely.
I think this is the another important angle Dr. Omesh Goel has talked about, is that it's a new concept that patients as a protective go on taking PPIs because they can enjoy the food, which is nowadays it's
So, I
become a
mean,
modern kind of food.
these things I'm talking all of practical things. They're not written in the books anywhere. So this is practically speaking, you have to tell the patient to stop this, because if you know, if the doctor knows of the side effects, then only you will be able to tell. Otherwise, if you're not aware, then you will let the patient continue, and ultimately they will be harmed.
I think there's two side effects as you have mentioned in PPIs. One is upper this gastric side effects and the intestinal side effect. Each and every doctor has to understand because the research is going towards, and one of the topmost gastroenterologists is sharing the views based upon the evidence and his own practice. So one is that the gastric protection of acid is very important for bacterial protection, and the mucin layer also is affected if the PPIs are taken. The second, he is talked about the bacterial overgrowth, which is another important problem if the PPIs are taken for long duration of time. So I think this is the important lesson everybody has to understand today, is that the PPIs can cause dysbiosis, which is, I think, it's very difficult to digest for every doctor who is using PPIs in his
Yeah.
60 to 70% of the patient, because of reasons which are even off level, you can call is reasons which are not indicated also, right?
Few of
Now,
the things which PPI, sorry, few of the things like which I want to mention is like ancillary enteropathy, like hepatic encephalopathy, like development of IBS, as I told earlier on. So these are also things. These are also due have been linked to overuse of PPIs. The patients who were on PPIs due to their various problems, the patients were found to have increased chance of hepatic encephalopathy. Patients who are cirrhotics, patients who had NSAID use, they had more chances of developing insect enteropathy. The PPIs don't prevent ulcers, they shift the ulcers from stomach to small gut. So in patients who having chronic NSAIDs, you have to see the reason. You have to give them other drugs for their pain, like use neuromodulators like pregabalin and other things, whatever the origin of pain is. But if you think you can prevent ulcers by giving PPS along with NSAIDs, you are wrong. PPS will shift the ulcer formation from stomach maybe to small intestine, and that is more difficult to manage. You don't have a direct test for small gut. The people who have small gut ulcers, small gut strictures, colonic ulcers, colonic strictures, we see so many patients with small gut and colonic strictures and ulcers, and they have bleed, which is difficult to manage. So PPS in fact increase the rate of NSAID enteropathy, which is, I said, more harmful and more difficult to manage.
I think just going to the legality of this particular case, the USFD has given some warning for PPIs, especially the topic what we are talking about is Clostridium difficile. So can you
Yeah.
elaborate to all the viewers about it? Yeah.
Yeah, see, the Clostridium difficile infection is a bacterial pathogen, which is quite harmful. It has lot many because of high mortality. High mortality, even in old age, even 70% people won't survive this infection. 50 to 70% won't survive this infection. That is why we consider it a very, 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 very bad infection of the gut. So one reason is PPIs, because it disrupts the mucosal barrier. This is the most common mechanism by which we don't have adequate pH to kill this bacteria. So when it enters your gut, you will get this infection. PPI increase the chance of getting this infection, and because of this reason, US FDA gave a warning in 2012. They gave a strict warning that overuse of PPIs may increase the risk of Clostridium difficile associated diarrhea. This is called CDAD. And because of, again I said, because of high mortality, everyone has to take care that we should not allow we should prevent happening this infection happening in our patients. And PPI are one of the most important factors linked to development of this infection.
Yeah, I think these all problems are critical. Like antibiotics and probiotics usage is there because nowadays the India is so modernized that we create medicines which are antibiotic with probiotic. Right? These are the combinations may not be available in the international market, but India is one of the country which is always innovative, right? So in medicine science also. So those patients who develop antibiotic into the area, you are protecting it with by giving. Now that kind of situation is PPI now. Probiotic usage, right? You are a gastroenterologist. Your all practice is towards gastroenterology. So what is that scope of probiotics now, considering the current as well as the research which is already there and the future dimensions to the research that where probiotics will be used in the practice?
So probiotics hold a very, very important role now, as in all diseases they have a role. So, but in therapeutically, if we talk, probiotics have an important role in prevention and treatment of diarrheas, like antibiotic associated diarrhea and Clostridium associated diarrhea. So, in these two diseases, they have a definite role, an emerging role. I can't say definite till now. They have an emerging role in prevention and management of these two type of diarrheas. And otherwise, if we see probiotics, they have been linked with other diseases like diabetes, obesity, IBD, IBS. I've already told. So in all these diseases, probiotics supplementation exact type of probiotic, exact duration of probiotic. The data has yet to come from randomized controlled trials because we don't have enough data to still say. But yes, antibiotic induced diarrhea and clostridium diarrhea, we there's a very good data in prevention and management of these two infections by giving probiotics. And The supplementation has to occur as per the patient profile. And the other things in which probiotics might help are like treatment of hepatic, as I told, hepatic encephalopathy, in treatment of IBS, and in treatment of skin diseases, in treatment of atherosclerosis. In all these, there are upcoming data, randomized trials are coming, but there are just few trials. We cannot draw a firm conclusion from these, but we have trials in supporting the role of probiotics in all these diseases also.
So normally in the gastro practice, because your gastro as a liver practice, when you give a probiotic therapy, normally how many weeks you give, or it based upon case to case? Yeah.
Yeah, I think there's still no firm data that I can say a definite conclusion. But yes, this is known that probiotics, when we give, they do affect microbial diversity. How many will, first of all, how many will reach the colon, how many will reach the small gut, because due to that, different companies are coming with different formulations so that we get adequate probiotics to our gut and colon. The duration, at least few months, has to be given, and there's no the trials are based on maybe 6 to 8 weeks to maybe 3 months the duration. And how long the effect lasts, this is a very very big question. If you give a probiotic for 2 months, 3 months, patient will improve. When you withdraw it, what will happen? There's no follow-up data available with us. But yes, obviously they will not have their long lasting effects. You might have to give repeated course of probiotics in diseases in which you feel that patient is having symptoms again. So in our practice, we give at least for 4 to 8 weeks, depending on the diarrhea resolution and other things. But in disease like chronic disease like IBS, there's no data yet. I cannot comment like how long they need to be given. More data is required for that.
Yeah, I think probiotics are finding their own place in the clinical practice. Like we give a vitamin D supplementation for short time, calcium supplementation, or the vitamin mineral combinations when there are deficiencies there for prevention as well as treatment. So similarly, I think the point which Dr. Umesh is talking to us is that the probiotics will be given for short 1 month, 2 months, 3 months in certain conditions. And again, it is required after 1 year, 2 year. If the similar kind of a situation happens, we can give that. The one point when we were discussing at that time, you told that the diarrhea patient, then definitely you ask the history of antibiotics. Now, considering this PPI usage, now is there any, every doctor should also ask that what is the PPI used in the last 3 months or 6 months?
So no need to ask. No need to ask. Every patient who has some prescription will have PPIs. So you just need to ask the symptom whether they really need PPIs or not, and then you have to withdraw the PPIs. So this is the most intelligent thing which any doctor can do, that you need to tell the patient withdraw the PPIs, and depending on the symptoms, you give probiotics, and I think the patient will improve. There those patients who have PPI-induced dysbiosis, stopping the PPI and giving probiotics for some amount of time, I think this will help. But the effect of like antibiotics, studies have shown that altered microbiome leads to IBD, inflammatory bowel disease. And the effect of antibiotics, it remains for years together. Even after 2 years, some studies have shown, even after 2 years of after taking antibiotic, they studied the microbial composition, it was still different. Patient had a short course of antibiotics, microbiome differed. I mean, the dysbiosis occurred. Even after 2 years, the dysbiosis remained. So this is the bad effect of antibiotic. We don't have this data for PPAs yet, but with antibiotic is certain that even 2 to 5 years later, dysbiosis remains, and patient can develop IBD due to the altered microbiome which occurred 2 to 5 years back. So this is certain. With antibiotics, they have long-lasting effects. Yes, PPIs, how long they will have, we don't have data yet.
Yeah, I think right, because ultimately it's a foreign drug, right? So whatever we are giving, the patient is taking, it is for solving the problem. So if it is taken in a high amount, whether it is antibiotics or PPIs, there is a chance of acute toxicity we are seeing, but there is something called as subacute and chronic. So as you are telling is that for antibiotic, this chronic toxicity of this virus is also there. But I think research is
Yeah.
ongoing PPI. If the PPI is directly causing acute problems or subacute problems, I think there will be some chronic problems also associated. That is a it's a matter of research, as you are telling, right? Yeah. So I think what of relevant and beautiful points come out in today's discussion, right? We started our discussion from gut microbiota, where the doctor has talked about one of the very important point is that 90% of the diseases there is some point in the probiotic, and I think 20, 30 years back that data was not there. So that is the
Hmm.
evolution of science, and being an investigator and researcher in this gastro field, doctor has rightly pointed out that fact. And I think antibiotic point everybody was aware, but doctor has emphasized upon the PPIs causing a dual effect, bad effect that is on not only in the stomach but also in the intestine and leading to dysbiosis. So every doctor should be aware that PPIs can cause dysbiosis to be used in the specific indication at specific duration. That is very, very important. And probiotics will become our friends in the co-prescriptions. Is there some place of
Definitely.
vitamins, minerals, and PPIs? I think it is there in every prescription. That we have to stop. But I think we have to replace that PPIs by probiotic. That can be a futuristic trend because always we are thinking about future, current and future. Therefore, it is very important. Any last point, sir, before closing this beautiful discussion?
Again, I would like to emphasize the same thing which your topic talk is based on: judicious use of everything. Anything which we are writing on a prescription, we should know why we are writing that. Does the patient really need that? And how long does the patient need that? These three questions we should answer in our mind before writing any drug on the prescription. This is the most important thing. Second, yes, the era of probiotics is emerging. We will have now, I mean, my boss used to say that every disease will be referred to a gastroenterologist for giving a proper probiotic. Maybe it's a cardiovascular disease, maybe it's obesity, maybe it's diabetes. So in the coming next 2 decades, I feel the future of probiotics is going to be, I mean, be very, very vast, and it will change the market of the drugs available. As more and more data will come, we will know how to modulate the gut microbiome to control that disease. Suppose a patient is obese, we just say, okay, take this probiotic for so long, and your microbiome will change, and you will be saved of obesity and diabetes. So, I mean, the future is very bright for this class of drugs.
So I think absolutely right. I think great work. GI health is very, very important because the Hippocrates long back told that food is the medicine and the medicine is the
Yeah,
food. So
yeah,
and probiotic component is already there in our food. We eat some curd and yogurt, etc. But we are very
yeah.
important. But as a therapeutic, you require a good supplementation. Nice discussion, sir. I think it's a great your researchers as well as your clinical views will help a lot of viewers because millions of views will be there over a period of time. Thank you all the viewers for attending this program. I think Dr. K. Agrawal, his remembrance is very important. He's spreading the science and the right science, evidence-based science, and making a mark in changing the practice of each and every doctor across India as well as globe. Thanks for IGCP, Heart Care Foundation of India, Talking Point, and USB. Thank you very much.
Thank you. Bye.